Started. Roll call, please.
All of the council, St. Paul, Community Center.
All right, let's go ahead and acknowledge the visitors, and then we'll come back and do our roll call. By then, maybe another trustee or two may show up. Go ahead.
Robert Casper.
Okay, now let's call the roll.
Mr. Arnold,
I'm here.
Mr. Albright.
Here.
Ms. Banks. Ms. Bell.
Here.
Mr. Brown.
Here.
Ms. Carter.
Here.
Ms. Clark. Dr. Elhai. Ms. Friedman. Here. Reverend Gordon.
Here.
Ms. Harding. Ms. Howe. Ms. Mendoza-Locke.
Here.
Ms. Rodriguez.
Here.
Dr. Sada. Major White.
Here.
Ms. White.
Thank you. The minutes of our last meeting, which was on October 1st this year, are pages 1 through 4 of your packet. Are there any additions or corrections? If not, I entertain a motion to approve the minutes.
So move.
Second.
Any objection? All in favor say aye.
Aye.
Any opposed? Any abstention? Motion carries. The minutes are approved. Jenny, we've got quite a bit of financial information here.
We do. They start on page 7. This is July through October of 2024, because it's been a couple months since we've taken you financial statements. So this is the start of our fiscal year 25 statements. And you can see we got our first section of levy revenue for the first half of the year, and we're right at budget there for levy revenue. In the federal and state revenue, we are showing over budget for fiscal year to date, and that is just due to timing of Ohio Moss allocations. We got it in October, I had it budgeted in November. And then you'll notice the big variance there in miscellaneous revenue. That is primarily due to Danny's Place, due to timing. So I budgeted that evenly throughout the year, but obviously expenses and revenue are not evenly coming in throughout the year. But we expect that to even out throughout the end of the year. And then when you look at grant-funded program expenses, you see the same difference there. About 1.7 of that $2.6 million variance is related to Danny's Place. And so for July through October, there was an increase in net assets of $3.7 million. Then I'm going to go to the balance sheet on page 8. We had an increase in cash, primarily due to the levy proceeds and our quarterly allocations from Ohio Moss. And then you'll notice some of the other big changes were in accounts receivable and accounts payable. And that is just due to the accrued revenue from fiscal year 24 being received and the accrued expenses from fiscal year 24 being received. And then our non-designated board fund balance increased to just over $17 million at October 31st. And there are a lot of payments, because it was 4 months worth, on pages 9 through 20. And there is a motion on page 6.
Is there a mistake?
Any questions for Jenny?
There was nothing.
Big bucks.
Motion toward the top of page 6 to recommend approval of the 4-month financial statement and voucher schedules.
Second.
Second. Any discussion? Objection? All in favor say aye.
Aye.
Any opposed? Any abstention? Motion carries. All right, Elijah, I believe you have the SOS 4.0 starting on page 21.
Yes, so there is some information here regarding the state opioid and stimulus response grant for criminal. In previous years, we were allowed to directly apply to Ohio MHRSB for funding the programs of kind of our jubilee that align with our priorities. This past year, they decided to do a competitive process for all boards and nonprofit organizations to directly apply to the state, which put us in a position to need to apply for some programming. So we asked all of our providers who had received SOS funding previously to do an application on their own. We submitted an application with 3 kind of priorities. The first being a targeted education campaign to promote our app, the Local Help Now app, the Mercy Mother-Child Dependency Program that had been receiving SOAR funding, but it's a priority because it's in our community plan. And then to use money to pay for treatment services to support our purchase of service through the use of these. You'll see kind of in the middle, page 21, Ohio MHRSB approved a lot of funding to Lucas County, including us. So each agency, all these agencies applied on their own. We had no determination in what they applied for, or even knowledge specifically about what they're doing with their funding, other than what they might share with us over the next few months. However, we were awarded $775,555. So it wasn't as much as what we asked for, but no program in the state received as much as what they asked for. So with this amount, we decided and flexibility from the state to fund 2 of those projects within our application, the Mother-Child Dependency Program, and several agencies to receive funds that we'll use for purchase of service dollars for individuals who meet the income eligibility and residency guidelines, along with having an opioid or stimulant use diagnosis. Those are kind of laid out in the motion, so each agency is going to have a specific amount, including Zeph, Center, Harbor, Unison Health, and New Concepts. And again, those are just to support kind of what we would be paying for with our purchase of service dollars.
How much did you ask for? I know you got the $775, but what was the original ask?
I want to say it was like 1.2 million.
I have a question too. So the allocation to these other agencies, will that lessen our responsibility in terms of how they utilize that money? Or do we still have to oversee how they spend that money, or is it's all on them?
No, we will do some monitoring. The application this time required fidelity monitoring, which is kind of along with what our long-term goal of how do we, make sure that agencies are providing quality services. It's kind of within our POS strategy of doing some more of that like chart review stuff. We'll talk about that later. But really, this is to help support kind of what we'd already be paying for with those. And then the Mercy Child Dependency Program, which again is a program that finds pregnant women who are using opioids and stimulants, helps connect them to treatment, and gets them connected with prenatal care, and kind of follows them throughout the pregnancy.
I think your question was with the funds being directed from Ohio MHRSB to Harbor, do we have any responsibility or those, do we have any monitoring responsibility? The answer is no.
That was my question.
We only have responsibility for the funds that we provide to the other agencies.
As opposed to years
Our
past
funds,
where we were responsible for all of it.
Correct.
That was,
Out of curiosity, who would monitor them, the state and
Yes.
Do we know if they received equal to what they were getting before? Or has that decreased as well?
So with all the other programs that were funded, or what we're funding them?
No, it's all the other, like Harbor got 239, 444,040 cents.
It's a little hard to say because we're not exactly sure we didn't receive their applications or review their applications, so they might have gone for something that we haven't funded before.
Oh, I see. So that's hard to say if they got more or less.
So we know
Got it.
like the health department applied for their harm reduction programming. And T. Whitehead is, they do recovery housing, so that's what they applied for, but the other ones may have applied for stuff that might be different than what we've
Okay, that's
provided
fair.
funding for.
That's fair.
So I have a question. So we previously got all this sum money and individuals didn't apply, right? So Zeph got $1 million from the state. And we're going to then take another $500,000 essentially to them. How is that on par with what they got from us when it wasn't an individual application?
Yeah, so this, for the programs we're funding for treatment services, we have not used SOS funding in so this is something new. This was kind of us trying to be proactive when we started noticing the significant amount of POS spending. How can we utilize other fundings to support that so we can better manage it? And so that's what these treatment agencies are providing. We've traditionally given like Zeph Center money for recovery housing. This SOS allocation that we have, that we are then allocating for them, is specifically for treatment services and not for recovery housing.
So at the end of the day, is this shifting any of our financial responsibility? I mean, does it lessen any of our financial responsibility for the services that we have been providing in tandem with these agencies? Or are we still where we were last year, except for the $775,000 plus?
I think that'll become clearer when we also talk about POS.
Okay, all right, I'll wait.
Yeah.
Well, the short answer is it's offsetting some of our planned expenses. We're seeing a rise and increase in treatment that we have not currently allocated funds for.
Okay.
If we did not have these funds, we would have to have we'd have to consider using local levy dollars to offset these costs.
Okay, can we perhaps similarly say that if these organizations that we do POS with didn't have the funds that are listed here, that there would be more of a gap between what we're funding and what the services they're providing? So in other words, are they hopefully using some of the funds they've received to offset those?
We can't say that.
But
We're gonna lead us into the next conversation
Okay,
where that may come up.
okay, all right, thank you.
Previously, we received several million dollars. So it's, regardless of what they specifically applied for, it's good that this money is still coming to Lucas County because of all this
Yeah.
SOS and SOR money we've received historically.
So just for clarification in my mind, the funds that these organizations receive are unencumbered for that agency, and there's no offset, correct?
Yeah, we can do that.
Can you ask it again? I'm sorry, I didn't hear you.
So the funds these agencies are receiving, they're totally unencumbered. So they can do it what they want to with them.
do it.
Whatever they wrote the grant.
Whatever they applied for. There's a process that Ohio Moss will use. They have to either use it for alcohol and drug, specifically methamphetamine or opioid-based services. Or they could make a case for something they didn't apply for, but still has to be opioid and
Okay, so in essence, no capital improvements, no operational costs?
Right.
Correct.
That's what I was getting at.
And that's what OMAS is gonna be monitoring.
That's OMAS made the decision to open it up and take on that responsibility, folks. Before all that money came through us, and then we applied our community plan to it. They changed the process, we applied our community plan, and the agencies got to make application to fit their needs as well.
And we don't have to monitor that money.
So
Does this leave room for the rise of another agency to take on those responsibilities and also desire to fund them?
I don't see that happening.
Do we know how Lucas County did compared to the other counties or how it's distributed across Ohio? Like compared to previous years?
You want me to handle this one? I might have a better idea. Previously, we received $3.4 million. Collectively, there's about 4.5 in here. According to what Ohio Moss said, they received quite a bit of applications, as you can imagine. They applied a formulary for the districts, so we're Region 6, right? We're the Northwest Ohio Psychiatric Hospital region. They applied a certain amount to that, and then they split the totals to based on a percentage of amount applied for. So we got 55% of what we requested. Other regions got maybe 45% because that's what they, that's what their percentage came out. The other region got 60% then. So we got our fair and equitable share, maybe even a little more.
Any other questions on the SOS process? All right, I'm gonna suggest, because you heard some hints of how it ties in, that we skip for the time being the next topic in your packet, which is the juvenile court, and go to the POS discussion.
You need a motion?
For this
Yeah,
first, we're gonna
yeah.
hold the vote.
Yeah, so I want everybody to have a complete explanation of how it all fits together, and then we'll come back and vote on all those motions.
Oh, separate. So what page are we going to then?
It is on page 23.
Got it. Okay, I see what you're saying.
Okay, purchase of service, see that at the bottom half of 23?
Yeah.
Okay, because I believe that will help explain some of what's going on with the SOS. Okay, Jenny?
Okay, so we've brought to you many times the increase in treatment service costs that we've been encountering. And we know that it's due partially to the increase in Medicaid rates that we mimic that was effective January 1st of 2024. So this fiscal year has a full fiscal year of the increased rates. We also know that there is an increase in the number of individuals served. So we've seen that in the data that we are actually, in the data that we pull in. So our current allocations are $4.4 million to our provider agencies for this. We are projecting from our agencies $1.6 million in overages. So our provider agency sent to us, if no changes are made, this is what we would anticipate we would spend for the year, for the fiscal year 25 that we're currently in. We have $1 million in our forecast to account for those overages. But if you'll recall, based on our forecast, that put us in below our minimum fund balance at the end of the forecast period. So that's just kind of setting the stage for where we are POS financial wise. So we think that the costs are reasonable given that the increased rates and the number of people served. But we also know that it's just not sustainable given where we are financially in our position. So we have had numerous discussions internally. We also met with the 4 largest treatment providers. We brought them in and had conversations about what their thoughts were on the best way to attack this emerging issue that we've had and ask for their suggestions for this. So ultimately, we have 4 suggestions. They start on page 24. So we are talking about eliminate Rider Code H on the subsidy schedule. The subsidy schedule is actually on page 27 if you wanted to see it. And this would be for new admissions after January 1st of 2025. So anybody, this is for benefit plan for for clients currently in 250% to 300% of poverty level. And this would only be for new admissions starting January 1st of 2025. So anyone who's currently in that can continue to receive the services. It would just be to not allow anyone new into that category. This would be a change to the provider agreement and is expected to save approximately $100,000 for fiscal year 25. The next item would be to reduce the length of time that we would cover treatment expenses for individuals with pending Medicaid applications. So you may or may not know, we give 10 days to apply to Medicaid, and then we give another 90 days for the Medicaid application to process. So this would be to change that from 90 days to 60 days. And then hopefully that would be approved and then retro back to us. So we don't know that there would be significant financial benefit or what that financial benefit would be, but we believe that by encouraging timely and correct applications, there should be some financial benefit coming out of that. That would also be a revision to the provider agreement, and that is section 5.2.1A3 in the provider agreement. The next suggestion would be to revise section 5.5.3A through D, and this would be to reflect a change from GOSH to our new electronic data interchange platform, SmartCare. So we've talked a lot about this as part of our ITP project. We will be going to SmartCare effective January 1st. So this is just a change in the wording in the provider agreement to change it from GOSH to electronic data interchange platform. And we actually noticed as we've been looking at some of the data that what we've been getting out of GOSH or have been able to get out of GOSH, we will be able to get so much more out of SmartCare. So when we've been looking and said, hey, can we look at the provider locations for this? Where was this provided? And we can't get that currently out of GOSH, but we should be able to get it out of SmartCare. So we think that's gonna be a good change. The last item will be not a change to the provider agreement, but just a change to how we actually process bad debt internally. So in the provider agreement, section 5.5.4, if an agency can't collect on unpaid copays, they can submit it back to us and it'll come out of their POS allocation, so we'll pay it out of their allocation. Currently, they submit it to us and we pay it right away. But we're going to hold that until the end of the fiscal year and only pay if they have money left in their allocation. So I know that that's kind of a lot that I just went through. That is what we anticipate we would like to change for fiscal year 25. We know that that's not gonna be enough to keep it sustainable, so we would like to probably continue to make changes for fiscal year 26 and beyond, so conversations are still continuing for fiscal year 26. Some of those discussions for fiscal year 26, you can see in the middle of page 24. We've talked about requiring copays on more services, changes related to Medicare and other third-party payer services, and capping service limits for TPS are just some of the other ideas that have come up in our conversations. So I'm gonna pause there before I go and talk about the money and see if anyone has any questions.
What's TBS?
Therapeutic behavior support, it's basically case management, skill building, that kind of stuff.
Changing it from Medicare from 90 to 60 days, is that, in the past, is that a good time limit, 60 days? Or are we gonna run into problems?
We think it should be, okay, yes.
If we talk to Job and Family Services, they say they would process a good application within 30 days. Good application, meaning accurate data. So technically, we're giving another 30 days to get the data accurate.
I guess the one that I'm most concerned about is the first one, when you said that you would not take on new patients. What's the impact of that? Because people are already in poverty and they can't get care, so like how many people will be refused treatment? Have you gone that far?
I don't have that number, but we can calculate that number, we have that calculation, we don't have it here, but you said something that I think I need to correct.
Okay.
People are in poverty. I need you to remember that what we're proposing is for people 250% of poverty to 300% of poverty. So that individual would, and I don't have it here either, but they would make over 3,000, if one person would make over $3,138 per month. That if they made over that, they wouldn't qualify for our services. Traditionally, that is where we had been up until several years ago, where we created this rider code H.
So, like, are there other organizations that they could go to, or they just out of luck?
Out of pocket, if they have private insurance, they pay their deductibles. The reality is, folks, and I'll say this, you've heard me say it before, we are going to have to make changes, or we're going to have to prioritize what we want to spend our money on, which means we will have to cut something else. Okay, so we need to, none of these decisions are things that we would want to do if we weren't in a financial condition 2 years out. So that's kind of the framework that we're working on. None of this is things that we wanna be able to do, but the reality is you can say, no, we don't wanna do that. But in February, plan on getting about another $300,000 to $400,000 worth of cost reduction recommendations of other programs, because then you've made a decision, you prioritize treatment services for people over 250% of poverty, which is fine. We just need the policy statement and we'll come to you with recommendations.
So, the other question is, okay, so that's kind of like on the back end. And I mean, it may not be us, it might be somebody else, but what about on the front end and preventative, so people are not in this situation in the first place?
Right there is where I'll bring that $200,000 to $300,000 cuts, because there's resource need is always going to outstrip resource, period. We do not have enough money to do everything we want and everything you want. So, yes, could we prioritize prevention? Absolutely, we could plow all kind of money into it. We'll bring you those recommendations for cuts because we don't have an unlimited budget. And so this board has made a priority statement of crisis, treatment, and housing. That's where our recommendations come from.
Do we have, through all of the additional data that we get, do we have the ability to gather the data that gives us a sense of, other than the 250 to 300% of poverty, characteristics of the people that this will impact? In other words, is it going to impact, will a large percentage of those people be families with children under, a certain age? Does it give us that kind of information, data that we can look at, characteristics of who any cut we make will more likely impact than others?
It gives us a lot more than what we've shared here. I'm sorry.
No, that's okay,
Okay.
it's all right.
And we did look at that.
Okay,
At family size, we looked at gender, we looked at race.
okay.
Um,
I just want to be certain that we don't inadvertently get into disparate impact situations with any of the things that we're deciding to cut. Like unintended consequences kind of thing.
So I also want to remind you that we're not intending to cut people who are currently receiving services.
Yeah, and I guess that also raises the concern if you have a group that are receiving services, and by comparison and equal treatment, so I just wanna throw it out there to put it on the back burner in people's minds.
We can provide some additional,
I don't really need it if somebody else is looking at it.
we actually did look at it.
Okay.
We looked at this quite a bit. But again, if you wanna make a statement of prioritizing treatment services for this population, you're welcome to do that. We then have our marching orders on know what we need to do to hit our budget numbers for next year.
Can I ask a two-part question? The first part was TBS, to go back, and then Elijah, just because I didn't hear over it. TBS, what I didn't hear what that included. I know it was therapeutic behavior support. What was that? Just because I didn't.
Yeah, so TBS is a code
Okay.
that can represent a number of different things. Typically, common vernacular, we would just refer to it as case management.
So with because I was just going over, it says changes related to Medicare and other third-party payer systems, and so is that separate from and capping service limits? So that's separate from and capping
Yes.
service on TBS. So is that going to be both for children and adults?
We've had conversations regarding all things are on the table right now.
Okay, so that will be a separate discussion, how the implications for
Yes,
children, adolescent, and adult, okay,
yes. Children are obviously still a priority for us, so
okay.
it's still a conversation we're having.
Just, I guess that,
Not till 26.
right, well, I'm just thinking ahead, because we gotta start talking about that now. I guess my concern is that I know it's still crisis treatment housing, but because we're now having to just remembering which children, adolescent, adults, and bringing those groups in to how they fit into who is the most affected by crisis, who is the most affected by treatment, who is the most affected by housing. Because we have those groups within that are built into each one of these emphasis groups, was just why I'm asking. And then going back into going back to the second bullet point, the immediate financial benefit is expected is unknown. Do you know, will we be able to have some idea like when you will have those? I know you don't know, but when we will have those numbers, just so we can see if that then if it does make a big difference, say 30 days, 90 days, 60 days, what that looks like, if that makes a big difference for us to cut it down.
So on that one, what should be happening,
Okay,
I will say it's not always happening, but what should be happening is when they submit a Medicaid application, they should be marking it as to be retroactive,
okay,
back to the original date of service. So when it goes through, they have that 60 days or they have that 90 days, but then it comes back as a retro to us.
okay.
But since that's not always happening, we don't necessarily know what that is going to be.
Okay, so is it the responsibility of the case manager and or the client that should be making sure, or the actual agency?
I believe it would be the case.
We're not gonna bite on that question
Okay,
because it's
sorry.
not our
I was just
responsibility.
wondering, like, who's, right, I'm just wondering where is it?
Our contract says the agency will facilitate a Medicaid application.
And if they make a mistake, then are they able to go back and?
I don't know if I would even call it a mistake. They operate with the information that they have available to them. But I think
But it's costing us on our end.
exactly.
Okay, that's
Exactly.
at the end of the day, that's, I hate to use those words, but that's what's costing, and it's causing other issues, so
It
we're
could
kind
be
of
billed somewhere else more
Okay.
appropriately than us.
Okay, thank you.
Any other questions for Jenny?
You did say there was a lot of
I know.
moving parts to
Yeah,
this
let-
one, didn't
let
we?
Let me take a stab at trying to pull the different threads of this together. If I'm reading this correctly, we're anticipating a $1.2 million shortfall in purchase of service for treatment. We have $1 million set aside for overage. That's not gonna be enough, and there may need to be other cuts, but what we're trying to do today is sprinkle that $1 million as best we can, plus the money that's being allocated from our 775 SOS money across these four main agencies.
Yes.
Okay, and if you look at the bullet point that start on the very bottom of 24, what I think you'll see is with respect to Harbor, New Concepts, Unison, and Zeph,
Right.
the combination of their original allocation, their portion of the $1 million overage money, and their portion of the SOS money for a new omnibus allocation for each of those four agencies.
Correct. Can I make one clarification?
Okay.
You mentioned 1.2 million in overages. That is what we calculated internally based on the information that we
And
had.
difference between 5.6 and 6.
Yes, the agencies projected out 1.6 million in overages.
Okay.
So when we calculated the amounts that we wanted, that we were going to propose, we have it at 90% of what they projected. Because we figured that it would allow them to cover a majority of their claims, but at the same time, it would allow us to keep some financial stability.
I also want to just state as well that we believe that we can, for a lack of better term, clean up our POS billing processes a little bit with some of these changes and some additional changes coming, recommendations that we'll make if needed. I think that's highly appropriate before we start to cut other programs. Clean up the POS process first and then invest in a process that is working properly before we start taking services away from other folks. Because let's be clear, everything we do from here on out will reduce services to somebody else. That's not avoidable anymore. Even with passing the levy and getting 5 million new dollars. So how do we manage our funds effectively for our highest needs individuals to make it last through our financial forecast? And that's our focus. We can do anything you want and we'll do anything you want. But we need your priority statements first.
Do we have a ballpark number of how many additional people are being treated?
So at our last meeting, which was in October, I referenced 500 plus additional service in 24. I've seen a number as high as 700, but I haven't verified that yet. So I'm reluctant, I'll say somewhere between 500 and 700, new. And that trend continues. This 1.6 is gonna turn into 2.6.
I think it's important for us to have that number so that when we talk about the costs increasing, that we can identify, by number, whatever it is.
We have it.
And I think so that the taxpayers, our stakeholders all understand what we're talking about, because it's twofold. It means we're penetrating the community with regard to the availability of services and people are taking advantage of them. But then the other side of the coin is the cost.
Well, there are motions starting in the middle of page 25. The first four relate to what we were just talking about, which is increasing, basically splitting the $1 million that we've set aside for overage among these four agencies: Harbor, New Concepts, Unison, and Zeph. But then there are three additional ones on middle of page 26 that I don't think we've really talked about yet.
Jenny referenced them in her presentation, that if you agree that we need to remove rider code H, then that's the first motion. The changing of the Medicaid timing
Okay.
is the second motion. And the third motion is the change in, to electronic.
Just housekeeping.
Yeah, it's housekeeping. The other thing I wanna say about this is these are the first four motions, and I think we do need to say this, are rather unique in their structure. Upon Harbor's approval, upon Filio's new concepts approval, upon Zeph's approval, because there is no mechanism in our current contract that allows us to make mid-year changes without mutual agreement.
It's a contract, you can't unilaterally change it.
There you go, right?
So do we have to deal with the motions on 22?
Yeah, we'll come back to those. Yeah, so I haven't forgot about it.
Okay,
No.
all right.
But those are separate, that's a separate pot of money, but it fits in here in terms of the overall allocation to these folks. All right, so we've got four motions, starting in the middle of page 25, that relate to the allocation of the $1 million. And then we've got three additional motions in the middle of page 26, which relate to necessary changes in the provider agreement to accomplish everything we want to accomplish.
Jenny wants to make one statement first on Zeph's motion.
So on Zeph's motion, it's slightly different than the other three. And that one is, it has a transfer of $45,000 from their crisis services grant, plus an additional $68,645 for POS. And that transfer of $45,000 from crisis services actually refers to the write-up that we skipped. Lucas County Common Pleas Court Juvenile. So we'll circle back to that, but I just wanted to point out that that is
Good.
slightly different than the other three, the first three motions.
That's helpful, thank you. All right, are we ready to vote?
We have a motion.
You made a motion?
I'll second.
First four and then the remaining three.
No, I think we can take them all
You
together.
probably should take them all together.
Yeah, because they all fit,
You can't do one
pieces of the,
without.
they're all pieces of the same puzzle.
Well, that's not true. You could eliminate or you could reject the H. And we'd have to come back with a different motion to figure out the difference.
We have a motion, we have a second. Is there any further discussion? What we're voting on is recommending to the board 1, 2, 3, 4, 5, 6, 7 different resolutions on pages 25 and 26. All in favor, say aye.
Aye.
Any opposed? Any abstention? The motion carries. And I want you to go back to page 22. On 22, we have, well, we have 6 motions, one of which is that the board accept the 775 in the SOS 4.0 funding. And then the next 5 relate to allocation of that 775 and explain what they are. So is there any further question or discussion that needs to be had regarding those motions? These resolutions are to be recommended to the board at its next meeting. Do I have a motion?
So moved.
We have a motion and a second. Any further discussion? All in favor say aye.
Aye.
Any opposed? Any abstention? All of those resolutions carry in one motion and will be recommended to the board. We are now on to the juvenile court. It's top of page 23. Elijah?
That was exciting.
Yeah, once in a while, we really dig into it, you know? Post office.
Okay.
So this, the juvenile court, they have, we've met with them and we've been engaging in conversation. They have noticed an increased acuity of youth in detention and need for more emergent services for those youth. They had previously been working with ZEP, the crisis provider, to provide some level of service, but through conversations, they agreed to kind of end that relationship, and the juvenile court is looking to have a more robust service for these youth in detention. So the agreement with ZEF, which is what Jenny referenced, some of that motion was for crisis services. However, they need more, and ZEF at the end of this calendar year will be done providing the services they provided there, leaving juvenile court with nothing at this time. So we're recommending $50,000 per their request to allow them to bring on a staff person, whether that be contracting with a licensed independent social worker, someone like that, to come in and provide some like crisis assessment and crisis intervention and work more closely with the youth in detention. And then we recognize that, you know, priority has been youth. We've said this in our levy campaign. So we are continuing to engage with them, and how can we really expand the level of service for those. So right now, we're just looking to approve this $50,000 to juvenile court so they can go out and contract with someone as we continue conversations on what's gonna be the best mix of services for these youth in detention.
Do you have a number of how many youth they're serving that would be in crisis that this $50,000 would be going towards that member?
So I don't have a specific number. When we've talked with them, they have youth in kind of, I'll just say, two ends of the spectrum. One in severe crisis. The other end of the spectrum, they really need someone to talk to that's not court staff. Someone to provide some emotional support. But right now, this end of the spectrum, these high acuity youth, really need a level of intervention that has not been provided previously.
Am I missing something? Where's the 50,000 coming from?
That transfer thing that Jenny was
It's
talking
levy,
about.
but it's basically offset by reducing ZEF Center's crisis
Okay.
service economy.
That's where that 45,000 floated away.
Yeah,
Okay.
so remember
It's
the
not an
45
apples to
transfer
apples,
from
but
that? Yeah.
we like rounder numbers.
So I'm still going back to the people on the high end of acuity spectrum. So what are the numbers we're talking about that one staff member is intending to provide crisis services to?
So this will be for any youth there in crisis, this is just kind of a stopgap until we figure out kind of what the mix of services they actually need. So I mean, it could be you know, a few a day. And we're not necessarily talking about like the level of psychiatric crisis that we typically see the crisis provider go to. These kids can be very escalated that day. And so this person would then come in and provide some support to the staff and be that an additional person that's not court staff. And that's something they kind of made it very clear. Well, the court staff can be, you know, trauma informed and supportive. They're still the court staff.
I just wanna say, in working with
Major, do you know what
juveniles,
the
that
census is
I know that
at the detention
they
center?
don't always trust the court staff to be confidential. And they're always fearful that some of the things that they say may be taken wrong and put in their court records. And so, and it's not necessarily true, but that's how they feel, and so they'd rather speak to someone who is not court staff on certain areas. Don't misunderstand, not everything, but sometimes they need that. They need that support.
So we've talked about different numbers. Our conversations with them have really just focused on some individual cases that they were really struggling with at that time. We actually have a meeting with them next week to continue the conversation. Say there's about 42 in detention, and that's gone up since the pandemic.
So I guess what I'm hearing, just so I know what is down the road, you're calling this $50,000 a stopgap. So then we will have further conversations about what our presence will be in terms of helping a crisis situation for juveniles in detention. Correct?
Yeah.
Yeah, and that was where I was going. We have no idea how much this could grow, correct?
Well, it's gonna grow by a number that we're
And if
gonna
it-
stop at.
It's gonna grow by the financial forecast.
Well, that's my next point. If it does, we don't have the resources to.
But the juvenile court is responsible for finding its own way out of this. In other words, finding their own resources and monitoring their own resources. And we're basically, I think of this as a pilot program.
Thank
Giving them money to set up a pilot and see how that works and maybe do, with our help, do something different next year, whatever.
So we've been funding, if I may, we've been funding crisis services in juvenile detention for years. We've, what's unique about that is it's until we make an allocation for the Lucas County Adult Detention Facility, which will be coming shortly, the recommendation. That's the only detention facility that we actually fund. And what's more unique about that is we don't tell anybody else which provider to use in their facility. And this was just, by default that Zeph ended up doing it because Rescue did it before that, correct? But they mutually have decided that it's no longer in their best interests to have this situation set up. And so we don't have an obligation to fund detention facilities. Care, custody, and control is firmly in the place of the sheriff in the adult facility and the administrative judge in juvenile detention facility. But the downstream impacts that quality care can have will improve our crisis services, will improve our access to hospitalization, will improve our engagement in treatment services, will improve the long-term continuity of care for all of them, which all means better outcomes for clients.
And their families.
And their
Thanks.
families.
Thank you.
I understand the need, and it's great.
Mhm.
I can assure you of that. My concern is who is governing this person? Because they will not be an employee of the court. Who will be monitoring that? Who will they answer to?
Well, they'll answer to court administrator for now, Said.
So they will be a court employee.
I would think they do it on a contractual basis, and there'd be a scope of work that has to be met during the 6-month period.
Which is the way it actually happened with Zeph Center. While they answered to us for their contractual obligations, day-to-day operations was with juvenile detention.
Gotcha. Okay. And this is a temporary thing until juvenile court can
6 months.
come up with their own solution to the issue.
Well, we will be working with them on a solution. And that could be using some of the new levy money to support expanding services there to meet their need. I don't wanna go into kind of what that looks like, cause it's still water on the table.
Sure.
They're still kind of assessing their needs and what their
So it could be partnering with another agency,
it could
it
be,
could be creating a position within their own structure.
could be
we don't know what that's gonna look like yet.
reallocating some of their grant funding they get, could be supporting a med management with these kids for some psychiatric med management.
I 100% support putting something in place, cause we can't have nothing there.
Yeah.
So I'll move.
I second.
We have a motion and a second to approve the recommendation in the middle of page 23. Is there any further discussion on that motion? All in favor say aye.
Aye.
Any opposed? Any abstention? Motion carries. On to ARPA.
Am I
Mr.
up?
Scott? Yes.
Let's take a moment to congratulate Erica White on her I just thought this moment of levity needed a little, we need to take a little break.
I thought you were about to kick me out, Scott. They take a little sign.
That'll be.
Not yet. It's coming up, I know. Everybody's been, every board I've been to and every place I've been there, like, hey, Erica, we seeing bye very soon, so.
Okay.
Give me a
Thank you, I
moment.
You're gonna help
appreciate
us in a whole.
Yeah, let me-
I've seen it.
we're almost through it. And folks, we knew that these were heavy topics to have in a meeting. We've been setting up the POS conversation for months. Knowing that there were difficulties ahead. So these are great conversations to have. You may also, if I may just.
You've got the floor.
All right. You may also start to wonder, well, isn't it time for us to rethink about our strategic planning process? Yes, it is. It's on our radar for the February-ish time frame where we'll start planning, do our RFP, and then we'll get you a timeline. Well, our current strategic plan is still in place and the timing is still good on that. So just, things are starting to shift a bit. We're seeing an increased cost in treatment services, which is a good thing if more people are getting care, right? It's just we need to think about what we're able to do in that space and how we should be doing that. But a little bit lighter agenda item is the City of Toledo ARPA. As you know, City of Toledo gave us $2 million a couple years ago. The majority of that money went towards the community mental wellness grants, formerly known as mini grants. And several other projects. Our last meeting, you allocated a portion of the ARPA funding, $75,200 pending City of Toledo approval, to a new project called the Mercy St. Charles Hospital Access Collaborative. By the way, since that time, the City of Toledo has made approval, and they have also authorized, should you grant this next recommendation, all the changes that are being presented. I would encourage you to think about the numbers that I'm about to give you independently, because if you start to try and add them up, they won't make sense to you. Because they don't make sense to me. But we've had about $91,000 in underspending in the community wellness over the several years that we've been running it. We're recommending that we take some of that money, $66,000, and leave it in the community wellness line and run one more category, one more round, $15,000 or whatever that number might be, without any board match attached to it, through this next cycle. So we can spend that money through, we are about to announce, I think, the last round, right, Michael? So then we'll run an additional round that'll probably end up actually crossing our state fiscal years 25 and 26. If we have an allocation in our 26 allocation, great, we'll apply our 5,000. If we don't, we won't. But this is just a way of just keeping that 15,000, 20,000, whatever that number ends up being, project going. We're just budgeting 5 projects at 15,000, comes close to that 66,000, I guess. Projects, let me just say, the mileage we get out of the community wellness grants, it's great money for communities to have, agencies to have. We get so much exposure, we get connections to agencies that support our mission. It's just great that we're able to continue it. So we would recommend that we continue that. The other amount, 24,538, we just wanted to take that plus a little bit more that we had never allocated before and apply it to the hospital access project. We're really close to an agreement with all the parties. There's 6 parties now in the project. We're close to a mutual understanding agreement to launch on January 1. We're suggesting that we add let's see, the amount here is 33, right? Yeah, hospital by 58,379, so it's a 24 plus 34 basically. And build that budget up a little more. It'll serve 5 more people in the project. Let me remind you who those people are. They're the individuals who are constantly churning through the jail and the hospitals, if they could get into a hospital, through our crisis system and the homeless shelter. Misdemeanor charges, referred for competency, identified as incompetent and non-restorable. If they don't have a violent charge, which most will not, they cannot access the state hospital. St. Charles has agreed to develop this project to partially meet a community need. Let's be clear, they're not gonna take everybody. They are not set up to take violent folks. But what happens now is people languish in the jail, they don't get a hospital bed, and then they get released because the charges get dropped because you're incompetent, non-restorable, you don't get hospital, charges get dropped. If you don't get hospitalization within a certain period of time, they let you out. And then we restart the cycle. What we're trying to do is break that cycle a little bit. And run a pilot to see if we can actually make a difference here. So that's really what we're proposing. The money has to be allocated by the end of this month in order to be spent all of next year. Okay, so this is ARPA funds. And so you have 2 motions. If you approve these motions, we are confident that we will have all the money allocated and set up for expense. Did I miss anything?
Nope.
All right, thank you. Questions?
Is this voluntary or involuntary with respect to the individual who's incarcerated?
So, thank you for that. That's a great point. We spent a lot of time trying to figure that question out. So, just because you're incompetent doesn't necessarily mean you meet the criteria for involuntary hospitalization. So, that person would actually have to meet the criteria for either being a pink slip or probate to do a show cause order. If either of those occur, St. Charles will still have to file an involuntary hospitalization affidavit at the end of whatever period is, 3 days if it's a pink slip. I don't know what the motion to show cause time is. It's either gonna be 3 or 10 days, probably. It took us a while to figure that piece out. So my best guess though is almost all, and this, we would encourage it, that if they meet the requirements, that they actually be involuntary. Because the next affidavit that we'll file is forced medications. And if you're willing to take medications, great, no problem. And I guess you could be voluntary initially, and if the doc didn't think you were good to go, they could always file an affidavit later. So I wanna backtrack on that just a little bit, but my guess is knowing the population, they're gonna be mostly involuntary. That was a really long answer.
Thank you.
I have a question.
Yes, ma'am.
Could a judge, you said that they go through the court system, could a judge then like require them to go through this?
Not a judge, a probate judge.
Okay.
So when you become incompetent, non-restorable, your charges would get dropped because you're incompetent.
Okay,
Affidavit gets filed at probate court for hospitalization by Toledo Municipal Court. Now it's a probate case. Now it's a civil case.
got it. Okay, I was just
So Judge
thinking,
Puff.
a lot of these judges who see these individuals all the time, you know, what does this empower them in any way?
The judge that you're referencing is the judge we've been talking with. We've had extensive communications with Toledo Municipal Court and Judge Corey in particular. I don't mean to exclude.
Judge Corey. You're right, that's where that question came from. You nailed it.
I don't understand the numbers here, the increasing the allocation from 300,000 to 315.
So the 315 is because if you take, sorry, the 300 that was last year's allocation, we're adding essentially more to it based on the previous underspending. So it's not just underspending from this year, it's underspending from previous years that we're adding to it.
Okay?
That's why I said, take her for, she's explained it to me 4 times already and I'm still struggling.
Okay. We have these 2 recommendations to the board toward the bottom of page 28. We can take them together. Are there any further questions or discussion about those 2? Entertain a motion. Second. We have a motion and a second to approve these recommendations to the board. All in favor say aye.
Aye.
Any opposed? Any abstention? Motion carries. Health officer designations, we're back to Elijah.
Yeah, so at the bottom of 28 into 29, we have met with our health officer advisory group and reviewed 2 new health officers and 7 renewals. And you can see the demographics of the new health officers. The committee or the group reviewed and saw they met qualifications, all things were in place, so, you know, we're recommending them to be approved as system health officers, yes.
I'm asking, is this something I need to abstain from as I work with Taryn? Okay.
No, you're fine.
Any further discussion? A motion?
So moved.
Second? Motion and a second to approve these new health officers. All in favor say aye.
Aye.
Any opposed? Any abstentions? Motion carries.
Before we move away from this, at one point, weren't we being provided the ethnicity?
We get the demographics every quarter, don't we?
Okay,
We
all
do
right,
it on a fairly regular basis, not every day.
okay, all
Not
right,
every
thank
month,
you.
but every other month or so.
So we've approved, because what I heard you say was we're approving the new designation, but it is including the renewal, right?
I'm sorry, yeah.
Yes.
Okay.
Yeah, we're approving this motion, which is right sort of in the middle of page 28 and 29. And that includes everybody.
Okay.
All right, Elijah, explain Vital Core's problems to us.
I can explain this one. So Vital Core, as you know, is the provider providing all health services in the jail, including behavioral health. It came to our attention that the staff are also writing pink slips. So the issue is they're not jail staff, so they're not like sheriffs or police officers. They're not by Ohio Revised Code standards, allowed to write pink slips. So we then need to develop an agreement with them, just like all of our other agencies you've seen to, agencies who are traditionally contracted with us. But just an additional agreement so they can have, so Vital Core staff can then follow our process to become a health officer. That includes meeting the experience, license, and training requirements that are established in our policy. The thing I need to point out with approving Vital Core to have health officers is they, as an agency, are not currently Ohio MHRSB certified. By policy, we contract with Ohio MHRSB certified agencies. However, we are proposing this contract through the end of the fiscal year to give them time to be Ohio MHRSB certified because the process does take some time to do that. And we and Scott had said, we committed money to the jail, so they are going to have to become Ohio MHRSB certified at one point if we're going to live up to our obligation through the passing of the new levy. So this really is to allow Vital Core staff who qualify, who meet the requirements, to become health officers so they can write pink slips when needed.
Assuming that they get the certification.
Now, and then we'll renew the agreement after they get the certification.
So-
Because it is a need now.
So right now, who's signing those pink slips? The deputies that work in the jail?
So they have like a nurse practitioner who's qualified to do it. Previously, they had like a licensed social worker doing it, and we said, you actually can't do that. So this is just helping them get in line with Ohio Revised Code and freeing up some of their staff who could write a pink slip once they're trained and approved by us. Get them in line with that policy.
Is there a cost associated with getting them trained and approved by us?
So think of it as two separate things. The reason you're approving this agreement is because the policy actually says the agency must be Ohio MHRSB certified. So what we're expecting is the agency to meet all the other criteria, including the liability insurance and all of that stuff, but for the certification, for a period of up to 6 months, the potential health officers will have to meet all of the requirements of a health officer. They aren't getting anything special. They'll have to meet all the training requirements and all the other things, including the licensing requirements. It's the entity itself that can't meet the certification requirements right now.
So what is the liability lie? I understand the financial liability is not with this board, but what is the liability for provision of care and signing off and fiduciary relationship? What is that?
So I'm gonna answer about half of that question and maybe even get that wrong. We require an Ohio MHRSB certification. Ohio law does not. So that's just something we require. They are actually providing this services in other jails across the state right now as health officers, as close as CCNO. So Lucas County resident goes to CCNO, they might be able to get pink slip by a Vital Core staff member. They can't do that in Lucas County because we've set a policy, we want Ohio MHRSB certification. And that's partly to make sure that the entity itself is meeting all the requirements of a certified entity, which includes all the staffing and all the liability and insurance and all of that. So I haven't answered your question directly yet. I'm gonna answer it directly. The agreement will require that they have, just like all of our other agreements, they maintain the liability.
So in essence, the board is just bailing out the county for something they should have done when they let the
Well,
contract.
No, because we had deputies who are authorized to sign a pink slip.
So, okay, so.
This wasn't anything that,
Legally, a law enforcement officer can do a pink slip without being a health officer, and that is what has occurred in past. However, I think what will be can be shown is that that service is probably better done by a trained behavioral health care professional.
So okay, let me start with this question. Where is it in our governing documents that we require this entity to be OMAS certified?
Or designation of health officer policy.
And is that's something that we read, we vote on, and?
Yes.
Okay, so you're basically asking us to suspend that requirement.
For this entity,
Okay.
for a period of 6 months.
Okay, and the reason, in part, that we have that requirement
7 months.
is part of Calvin's
Part of
question,
Calvin's question.
it's risk management.
Fair enough.
Okay, so what we're talking about doing, if I understand this correctly, is we're talking about making this exception immediate, pre-certification, pre-OMAS certification, so.
Correct.
Just to allow the agency to go through the process of having health officers. So we do, our county does have a robust health officer policy that's different from several other counties.
Yeah,
We
but
were-
there was a reason that we
Yeah.
decided to do that, and I guess, have we fully looked at in the interim, while they're becoming certified, whether we truly wanna suspend and have whatever risks are associated with what caused us to put that policy in place in the beginning. Number one, and number two, if we say no, what workarounds are already in place that don't undercut the potential risk that caused us to put this in place to begin with? In other words, can they, go to an officer? Can they, find, whatever? I don't know what the options are, but is there some option that doesn't open a potential Pandora's box? Now, while they may agree to assume the liability, that's between us and them. That's not between anybody that might bring a cause of action. And then we're in a situation where if there's any exposure, we gotta go back against them again to get reimbursed.
That's fair.
So, devil's advocate.
I would suggest we pull this. I would suggest we table it, run it through the prosecutor's office.
Okay.
County risk management.
Okay, I was gonna say that
And just talk
it's
it
gonna have to
through.
be a very robust memorandum of understanding, because basically what you're gonna require them to do is have in place everything they need to be OMAS certified before they actually get the certification.
That's
'Cause
not
that's
what
the
I
only thing that's gonna
understood.
protect us.
That's
And
not
if we have a
what I
contractual right and a right of indemnification back to us, that they have done all these things, then I think we're probably okay.
Well, yeah, but that means they're not gonna be writing these slips tomorrow. Or after the day after the board meeting, because they won't have everything in place. They won't have their insurance coverage, all that. I would just suggest that.
The other thing that crossed my mind when I read this is, does it open this up for other people who we've said, no, we won't fund you because you're not Ohio MOS certified, and we didn't offer this to them?
I would say that if those other people were providing a contracted treatment services within the jail, that argument might stand.
Okay.
So-
But for me, I was just like, just thinking globally, like, oh my
but
gosh.
This whole thing is, first of all, let's remember the success of Vital Core. Their success is our success. We wanna do things the right way. They're showing great progress there, things are going well. is a way of collaborating with the county, and not throwing, I don't know, barriers to getting people care.
But we're making exception to our own policy to do that.
Well, that's why it came up in front of you, because otherwise I would have just said, okay, and signed it, right? You would have got a different policy, you would have got a different motion. And when I read that, I'm like, nope, this isn't me, this is the board, because I can't change your policy.
Yeah.
Only you can change it.
I mean, if
So
if
this
there,
is why we're having the discussion.
so I guess I would say, I would be interested in hearing why this doesn't go against whatever the rationale was that caused us to put that policy in place in the first place. How this doesn't adversely impact that.
So I'm not clear.
But I only have one vote.
I'm not clear on why the robust policy was established. That predates all of us. But I am personally a fan of a more tighter
Absolutely.
officer policy when you're taking somebody's civil rights away.
Yeah, so the thing is, if we still feel that the robust policy is valid and we're not prepared to let it go, then,
I have my answer.
but I only have one vote.
No, I think you got.
I disagree.
I think you got more than that, so I think I got a clear understanding of
Yeah,
what we're
I don't
doing.
have a level of comfort like this. I think they should.
Okay, well,
We're good.
let's table that. We're not gonna have a vote on, item number 11 in your packet, your agenda. We will remove that and, staff will figure out what to do about it. All right, open session. Richard?
A lot going on in government center, I don't need to try to summarize it, let's just say they're trying to make a budget in the city, same time all the time. Shared services building is coming up, so they want to expand the parking lot, they need a zone change, so that the zoning and planning committee of city council, minimum 400 citizens, only have to show up. County commissioners are on the 8th floor of the building, but they didn't bother to come out. Even though it was on the agenda, they had after forum and nobody showed up. They still wouldn't have it. All the changes right next to the neighborhood. You were just talking about vital care. A couple of weeks ago, they have given some more money. Apparently, when they contracted with them, the county provided them with inaccurate information as far as how many things about their needs were. I'm quoting from the resolution. The data that we did have regarding medication was substantially inconsistent and not tracked in a format conducive to transmittal. I don't know what that means, but it sounds really bad. The bottom line is they've got to give them another $498,000, bringing the total contract to $5.1 million, and the jury is still out. This occurred at the same meeting where they had their budget hearing, and the sheriff was so mad that he got mad at Peter and he stormed out. He took his entourage with him. I wanted to talk to him. The Blade reporter literally chased him out into the hallway, but they wouldn't stop and talk. But they have to give more money to Vital Care, which they said was going to save us so much money. The only thing I know for certain is the care that inmates receive while they're in jail is going to determine what they do when they get out of jail. They're going to go right back to reoffending, or are they going to get their act together? So we'll see what happens with that. My editorial comment on the presidential election, I've talked about this before. This is the Columbus Dispatch dated September the 1st, 2019. That's just after the Parkland, Florida school shooting, which claimed 17. After shootings, Trump fixed on mental institutions. I think that title says it all. This is the Wall Street Journal dated February the 19th of 2020. The significance of that date is it's 1 month before the pandemic. We are not trying to change the fund in these giant psychiatric hospitals where people live out their life to die. Even our hospital here in Toledo, they have their own cemetery and first bill got the last time to go up, it's very much on the ground. It said we will not put any dollars in any facility that has more than 60 beds. And it's been that way for years. Pre-pandemic, just before everything was torpedoed, Trump in his first administration had bipartisan support to overturn that, which would pave the way to put a lot of money into institutional care at the expense of community care. Now, let me be very clear about my concern here. I don't think we're gonna go back to the state hospitals, but we're gonna talk about it. That's bad, and that's really bad. We're gonna hear that same lame argument that you hear from the Trump administration. If we just lock up the crazy people, we don't need any gun control. It's a lame, evil argument, but it seems to work. What Trump does is almost slick. I mean, when he's addressing a cheering crowd, he talks about he's going to lock up these sickos. But when he's talking to the news media, he tones it down a bit. Oh, we need to find out what he's pulling and pushing. What I fear is that this could be the end of community mental health. For the next 4 years, I don't think we're going to hear a lot of productive dialogue from Washington about intervention for children and prevention for adults and sport programs. Well, we're going to hear that same argument. Lock up the crazy people and it won't be the end. It's probably the best counter argument. I think that's what we're going to do. So what that means for this board and others across the country, we need a positive dialogue. We need to keep on talking, because when all people hear the news media is they're crazy people, and it's already started front page yesterday in Wall Street Journal about it called to bring back more institutions. When people read that, they're going to be less likely to discuss their mental health with friends and family. They're going to be less likely to see treatment. They will deteriorate, and eventually they'll become a problem for law enforcement or someone like that. So it's up to this board to maintain a positive dialogue, because I don't think we're going to hear that from the Trump administration. When Donald Trump talks about mental illness, nothing will promise. That's my editorial opinion. Thank you, Richard. Anyone else in the audience? Need the floor? All right. Seeing none, we're adjourned. Thank you.
Thank you.
Statement, please. Again, those of my colleagues who have not submitted their